Thanks, Tom and Sages, for the opportunity. What I'd like to do is give kind of an overview of something we've been working on for almost a decade, and that is applying data science and system science to any attempt to try to improve our outcomes. And ERAS has really been an incredible advance in our ability to look at our process of patient care and implement ideas for improvement. And there's lots of different ideas that include in ERAS, from prehabilitation to multimodal pan and enhanced recovery. And I'll just talk about how we can maybe assess the impact and how we can use continuous improvement to try to continually improve. And I do have disclosures, mainly hernia companies. To help me understand, I really had to understand the foundation for our healthcare system and our scientific paradigm really came from a reductionist science. And that's Isaac Newton and the scientific method. And what's happened, I think, is we're beginning to see the incompleteness of that scientific paradigm. About 20 years ago, some astrophysicists found out that our universe is actually accelerating in its pace of expansion. And we see that in our waves of innovation over time, from the agricultural revolution to industrial revolution, the information age. We're seeing the pace of change in our world increase faster and faster. And what this leads to is, in a reductionist model like we have in healthcare, it leads to increasing fragmentation. And we see this as building the waste and inefficiencies. And the amount of administrators required to deal with that increasing fragmentation has increased significantly. And we have this issue when we're trying to implement process improvement. This is just some of the pre-op, intra-op, and post-op process improvement ideas in our hernia ERAS program. And you can see there's so many different factors, there's so many components. It'd be very, very challenging to design a prospective randomized controlled trial. The other thing we're dealing with is incredible biologic variability. Our patients are not one size fits all, and we're realizing a more complete scientific paradigm is probably going to be required. What we've tried to do in reductionist science is pull out individual factors and individual outcomes measures and try to isolate them in an isolated environment and try to prove or disprove a hypothesis. And that's very challenging when you have such a complex system with many factors interrelating that produce outcomes. And we really are beginning to realize we can't control all variables, that things do constantly change, and the results we generate in one local environment may not be applicable to another. A book I read, it kind of hit me. This is what we tried to do in healthcare, The End of Average by Todd Rose. They talk about the air crashes that the Air Force was having back in the 40s and 50s. And what they realized was, at first they thought it was human error. On one day, 17 planes crashed, and that wasn't in conflict. That was just exercises, 17 crashes. They looked for human error, they looked for mechanical failure, and it took them years to realize what had happened is years earlier, they had done over 120 biometric measures of all the pilots. They tested their waist circumference, arm length, head circumference, and they built the perfect average cockpit for all the pilots. The problem was, it didn't fit any of the pilots. And so it was really the pilot-cockpit interaction that led to all these crashes. And so we really have to be careful when we try to average in a reductionist model research and try to apply that to all patients. And when I looked to the textbook, Introduction to Standards and Standardization, I saw that the true definition of standardization is not uniformity, but it's actually optimal variety. So understanding what is the system science and data science that can help us determine optimal variety of enhanced recovery pathways, of treatment pathways for our patients. And this is much more of a real reflection of what we deal with in a complex biologic world with many, many factors that interrelate, and they're constantly changing, produce at any one moment in time many potential outcomes. And understanding how to define and measure those factors, and they can be multimodal pain, enhanced recovery factors, early nutrition, prehabilitation, and look at the outcomes. So I'll just share with you a work in progress, what we've been working on. And I will say this is beginning to get into the literature that complex system science paradigm tools like clinical quality improvement, nonlinear analytics are going to be more and more, I think, valuable as we continue to deal with increasing complexity in our world. And ultimately, I think we all want to learn what is the value of care we provide. You know, that's the measurement that we're trying to develop for entire cycles of care in definable patient process, whether it's going to be very different measurements for a hernia patient than a liver resection patient, and we need to understand those differences. We have an unbelievable, robust amount of nonlinear analytical tools. I'm in Knoxville, and Knoxville is where Oak Ridge National Laboratories is, and we have over half a dozen incredibly gifted data analytics groups that we're working with. And the tools are quite varied in terms of being able to identify patterns, subpopulations, and do predictive analytics. And really what we're looking for is identify those clusters of patients that we can better and better predict outcomes and measure what we're looking to measure in terms of value and measure the impact of any improvement ideas like ERAS that we implement in our patient process. We've done this with our hernia program. It's, I think, important to note that we have the authority as physicians to do this. We have the authority to look at our data, implement process improvements, but we also need to do that very responsibly. We've tried to do this in a team, in a multidisciplinary team with the patient care manager, including the patient and family on the team. We actually, because we're a hernia program, we have a materials scientist on our hernia team. There's also more and more good literature and books. This is a physician at Harvard who talks about the opportunity we have to not just do patient care, but to learn from the actual care that we're delivering. And it's, I think, an excellent book. And so it's understanding the differences in the tools from a reductionist science paradigm, which are prospective randomized controlled trials where we try to prove or disprove a hypothesis, and it's a static protocol with attempt to control all variables. Well, the continuous quality improvement or continuous value improvement tool is continuously adapting. You can change things in real time. You can measure things in real time. And it's really about improving whatever you measure, not trying to prove or disprove a hypothesis. We try to do this as a team, and it really gets fun the more that you get good data and analytics, and the team can gain insight into what would be likely to help a patient and what would be likely to be a good component of an enhanced recovery process. We are coming out with a policy statement as an institution that this is not human subjects research, that doing real-world continuous quality improvement and measuring our outcomes and doing analytics should be a part of our actual patient care, and it's inappropriate to go through IRB. The laws have supported this and supported us as clinicians to do this since the HIPAA law in 1996. It's a very specific exclusion from the HIPAA regulation that if you do care coordination and quality improvement activities, you're exempt from HIPAA. And so we've tried to do this as a hernia program. Again, we've implemented many types of process improvements. The first operation on this gentleman, we hadn't implement them. We had a chronic wound complication, recurrent hernia. The second operation, we had implemented a number of enhanced recovery protocols, and he was in the hospital 3 days. We've done this with complex abdominal wall operations. This lady had a massive resection of skin, soft tissue, colostomy takedown. Her tattoo used to be on her right buttock. Now it's on her right lower quadrant. And she was in just 3 days. This patient had had 5 prior abdominal wall reconstructions, starting with a tram flap and then infected mesh. She was in the hospital just 1 day. Now, we still don't have great results with everybody. This is a recent patient, was in the hospital almost a month. So we always have opportunities to improve, and we're still trying to figure out, we probably should have done more prehabilitation on this gentleman before we operated. But we have looked at outcomes, looked at data, and through the multimodal pain and enhanced recovery implementation, we've been able to get a fairly large subpopulation of patients with these very complex abdominal wall reconstructions out of the hospital in 3 days or less, about 35 or 40%, and I never would have believed that 5 years ago. But it's an iterative process of continuous improvement and measurement. We've done the same thing with our laparoscopic ventral hernia repair patients, which is can be a very painful operation, and we've been able to see a decrease of opioid use by almost 80%, and over 60% of patients wake up in the recovery room with little or no pain. And this is through multiple things, not just one thing. It's long-acting local anesthetic, it's low-pressure pneumoperitoneum, other multimodal non-opioid-based pain strategies. Another brief thing as far as continuous improvement and measurement of our outcomes, we can measure things that we think of at any moment in time. We had patients question that we told them their block would possibly last 3 days, because that's what we were told by the industry. So we measured the last 25 patients, and asked them, when did your block wear off? And this is what the response was. Some of them, they didn't feel the block worked at all. That was 0. Some of them, it lasted 6 or 7 days. The largest group of patients was 4 days. So this is much more reality. So when we see patients now, we can share with them that their block may last not at all, or it may last even longer than 3 or 4 days. So this is much more of a reflection of reality than just saying the average, the block's going to last 3 days. There's also tools, again, for nonlinear analytics. This is called a scree plot where it looks at combination of factors that have weighted correlations that impacted outcomes that you measure. This is something we learned about 5 years ago, and we were not even measuring this, but the highest weighted correlation to predict outcomes for our hernia patients was the emotional state of the patient. The other 2 higher things were number of recurrences and size of the hernia. We couldn't do anything about that, but we could do something about the emotional state of the patient preoperatively. And so we've implemented cognitive therapy for some patients who score high on things like anxiety, PTSD symptoms, or anger. And so this is a review that was published out of Europe just last year about how, when we implement innovation, like implement an ERAS recovery program, an enhanced recovery program, how should we be measuring this? How should we be looking at this? And they're really moving in this direction of system science and data science, where it's not just do something and measure it scientifically. It's do something with the intent to morally improve our patient outcome and become more of a learning health system. And so one of their conclusions is this environment needs to be not the typical traditional surgical environment, but an environment where learning is perceived as an ethical imperative that requires culture characterized by self-reflection, vulnerability, and willingness to change. And I think we are all moving in that direction. And so kind of a summary, I'd say the keys to assess the impact of an enhanced recovery effort in the 21st century really is aligned with the systems and data science, using a multidisciplinary team and a learning system, using tools from systems and data science like CQI and nonlinear analytics, and engaging the patient and family as part of the process. And a lot of the ideas can be generated to improve the process from their perspective, and be transparent about our outcomes. And I know it's a significant challenge, but we really should be trying to measure the value of care we provide. And we're moving from the concept of reductionist science, where the thinking was our human body is like a machine, to one that is much more reflective of our true biologic variability, where we're a complex and adaptive system. And we can't do anything about the fact that the complexity and the pace of change in our world and our universe is expanding faster and faster, but we can learn about a more complete science to apply to deal with it, and I think we're doing that. So I want to thank you very much for the opportunity to share with you.